We talked about C4A being released from following ficillin detection, as well as acetylated compounds. And usually these are glycoproteins. Usually these are sugar moieties that are detected by MASP2. So lectin binding is critical in all this stuff. And some of the chemistry I wanted you to know yesterday really does apply to patient care. We know that you will find high C4A in people with cognitive deficits, restrictive lung disease. Be looking for C4A and TGF-beta1. Remember, TGF-beta1 turns those nice columnar lining cells into thick, tough, fibrous tissue, fibroblasts, that epithelial to mesenchymal transformation. It really returns differentiated cells back to their primordial precursors. Just amazing. We know that you can find C4A rising in mold patients. If they're exposed for an hour to water damaged building, you measure C4A, 4 hours later it's going to go up. We know that in people shown to have Lyme disease, they're seen hyperacutely, C4A is going up within 12 hours. And it shouldn't be any surprise. We see this in cell-free systems. If you look at the Lyme paper, which I mentioned to you yesterday is number 38 in your packet, Dr. Barber gave us pure cultures of Borrelia burgdorferi and Borrelia hermsii, and we added it just to plasma, and you get the same results that you do in people. The C4A summary page, this is an older one. The one that you have is number 5 in your packet. Is readable. This is too small, but we've looked at C4A in a large number of different conditions, and it really does make a difference. If we look at your people who've had Lyme for a long time, 8,000 or so after antibiotics, it doesn't change. After you use biotoxin mechanisms, it falls very nicely. For our mold people who are acute, levels are very high after treatment. The treatment with biotoxin stuff does fix C4A down to about the same as acute Lyme, which is not too far away from our control patients. Same way with our dinoflagellate folks. The erythropoietin that we use for the very worst patients doesn't work quite as well, but it brings it down very nicely. But the critical thing I've been telling you about C4A and sicker quicker is that your relapsing patients, instead of a mean of around 10,000, 11,000, your mean is 22,000. There really is a difference in C4A in your relapsing patients. To summarize it, it's on the slide you probably can see. This is an older one, but we've got a lot of patients in this data set, and these numbers are staying about the same over time. Untreated is 12,000 for the first time around, relapsing is 20,000.